Okay, thank you very much. I really appreciate this very, very, very kind invitation. And anybody who wants to know where I really am, and it's not really Seattle, I'll talk to you after the conference. The other thing is that I have a lot of slides, more than you're supposed to have in a 30-minute talk, and I know you guys are anxious to go and look at posters and drink some wine. So what I'm going to do is, a lot of them are pictorial, and I'm not going to spend a lot of time trying to explain the pictures because that can really bog things down, but I'll go quickly through those. But I do have some slides where I want to read you what's on the slide because I think they're very important and they really complement some of the things that we've been hearing. I really appreciate coming at the end of the day today because a lot of the things that I'm going to touch on briefly have already been introduced, and I think I removed most of what was somewhat overlapping that I heard earlier today. Very quickly, the disclosures of companies that I've had some involvement with. Nothing of concern here. And so the topics that I'll try to cover briefly will be, and I did this in a funny order. I just wanted to get people excited about the use of the checkpoint inhibitors. So I put in the material about a trial that's still ongoing of pembrolizumab in patients with brain metastases first. It's not my trial. Ipilimumab in melanoma overall and for patients with brain metastases, but I wanted to point out this slide was done yesterday, so it was the day before that the US FDA approved the combination of IPI and Nivo, and that's going to change a lot of things, both in terms of clinical trials and in terms of clinical usage. Some of the biology and immunology supporting immunotherapy for melanoma patients with brain metastases, a little bit more about radiotherapy than we just heard, which I think will be, again, a nice complement, and then maybe something about future agents that could be used in combination with checkpoints or with each other or with other existing immunotherapies or with stereotactic radiosurgery. So just one quick thing about historical use of drugs that really we're not using now, and I pointed out in a slide that I used before that the use of temozolomide and its enthusiasm in the old days was really what I think was an example of faulty logic. And so was sorafenib for that matter. But focusing on the temozolomide, it's essentially the same as dacarbazine. The metabolite is the same for each one. They have the same effect on DNA. And in the case of temozolomide, it was exciting because it crosses in large part an intact blood-brain barrier, so it was thought that it would be great for patients with melanoma metastatic to the brain. The problem is it's only as active as dacarbazine, which is about a 10 to 12% response rate on a good day. So this was the example, I think, of faulty logic, and it's really gone by the wayside. It was used in a couple trials, even together with whole brain radiation in the days before the SRT, and it was just a pretty worthless approach. So that really opened the opened the doors for SRT or SRS, I'll use those interchangeably, and various other immunotherapies. And I had a couple of slides, I took them out for length, but IL-2, interleukin-2, used in high doses was the first immunotherapy that was approved in the advanced disease setting for melanoma after many, many years of dry spell following dacarbazine many years before. And that drug was used very rarely in patients not only with active brain metastases, but even in those who'd had them, because the prognosis for those patients was still so poor, and there was concern that it might provoke seizures or increase the CNS toxicity that we often see with high-dose interleukin-2. So we don't really have a good assessment of how active it might be, but I think it's really, for the most part, become an almost obsolete drug, at least by itself in its current form for metastatic melanoma. It may be coming back in combinations or may have other forms of IL-2 that are safer and we can experiment with again. This is the entire poster from which I borrowed some parts of the poster from a presentation that was already given at ESMO by Harriet Kluger and Lucia Giuliano at Yale, together with other colleagues. And it's about a 2/3 accrued trial of pembrolizumab for patients with either melanoma metastatic to the brain or lung cancer metastatic to the brain, and focusing on their preliminary data of about 18 patients out of 24 that they're planning to accrue, 24 evaluable. This is some of the demographic data. I don't think it's all that important, so I'm not going to go over that in detail. But the drug activity, what they did was they called several patients inevaluable. I'm going to come back to that in a second. They were called inevaluable because of rapidly progressive disease. So they took 14 of those patients and reported those results, of whom they had partial response in 4 and stable disease in 3. Now, it's customary. We've talked a little bit about the strange and somewhat difficult to use immune-related response criteria that were born when ipilimumab came around, and I'll talk to you a little bit more about that. But it's often been considered, at least for ipilimumab, that prolonged stable disease is also contributing to the disease benefit. So they have coined sort of a term that was not previously used in cancer with cytotoxic drugs, which was a clinical benefit rate or disease control rate, in which you add some definition of durable stable disease to the objective responses, partial and complete. And I think that as we get to better agents or better combinations, we might eventually be able to dispense with that and go back to some easier to quantitate measures of benefit. But for the time being, that's what we use. And so some of their points were that the activity of non-cranial disease or extracranial disease was similar to that which was seen in the brain disease. And then there are some pictures, and I just want to point out, as you can see on the left, you have stains for H&E, and then for the infiltrate of immune cells, and then on the right you have evidence of the melanoma disappearing. So that's quite gratifying. What they're doing in that study is to actually use a special form of laser-mediated biopsies that will allow them to get as many tumor biopsies pre and during therapy as is safely possible. So we'll have more things like that. And these were just a few more pictures that they put on their poster, with the conclusions to date being that pembrolizumab does have activity against melanoma metastatic to the brain. And so it's melanoma metastatic to the brain, and it's patients with melanoma metastatic to the brain with respect to their extracranial disease. So having brain metastases doesn't mean you have a different kind of melanoma that's less responsive to drugs, which I think is important. I put in green that inevaluable patients really must be counted in studies as long as they were eligible. And I've been doing clinical trials for long enough to really appreciate how important that is. It's the same as the intention to treat. If patients fall off the trial because sometime between when they were registered and the time that they started therapy, their very bad disease progressed and became even worse, they still have to be considered, because that's the only way to compare them to what's going to be the real world use of these drugs following the publication of the trial. The immune-related adverse events, IRAEs, that result from these drugs were about the same, and there doesn't seem to be any signal of worse CNS toxicities. However, it is somewhat hard, as we discussed earlier in quite extensive detail, to document responses and benefit in these patients because they go through so many radiologic changes. So imaging is I think, to a certain extent, keeping pace with the design of these trials, as well it should. Okay, this is one of those diagrams I promised I don't want to spend a lot of time talking about. It was published by Tony Rebus in the New England Journal some time back, and it's just to show you a little bit about the connection between, or the contrast and the similarities between PD-1 blockade or PD-L1 blockade versus CTLA-4 blockade. And I have another picture that blows it up a little bit more. It's from a different source and shows you that, I wish I had a pointer here. Maybe this is it. No. And anyway, the T cell is in the middle, and as you can see with the long oblong circles that I've made, that the antigen presenting cell interacts with the T cell through the PD-L1 or PD-L2 and the PD-1 receptor on a T cell that's been activated. So as soon as it's activated, it starts to go through its programmed death cycle. CTLA-4 also on the activated T cell interacts with CD80, also known as B7-1, on the antigen-presenting cell, but also on the tumor cell, PD-1 on the activated T cell is also liganding with PD-L1, which can be constitutively expressed genetically on the cancer cell, or it can be expressed either epigenetically or some other adaptive way by the tumor cell, which may be a good thing or a bad thing depending on other aspects of the tumor microenvironment. And the T cell also, once it's been activated, immediately starts to express CTLA-4, which bumps CD28 off the antigen-presenting cell. And so both of those checkpoints are the ones that we're trying to interrupt when we give either CTLA-4 blockade or PD-L1 or PD-1 blockade. Some of the unique kinetics of this ipilimumab response are what I was referring to when I mentioned the immune-related responses, and they are outlined here. Verbally, you can get prolonged stable disease followed by regression, which is rarely complete in the case of CTLA-4 blockade. You can get new lesions, and that's the key thing behind the immune-related response criteria, which is that the standard RECIST or World Health Organization response criteria do not allow any new evidence of disease. That constitutes progression, whereas the IRRC were adapted to basically take into account the total measurements, even if there was a small new lesion, as long as the total measurements did not surpass that which is allowed to call it stable disease, that would be permitted. And the reason for that is twofold. One is that a small new lesion may just represent the immune system taking a while to control something that was growing very slowly and that you didn't see before, but now you see. The second possibility is that infiltrates of inflammatory cells and maybe a little edema or some vascular changes could make lesions more visible, even though there may not be more malignant cells in those lesions. And then finally, you can actually have objective progression that is followed by objective regression, and I'll show you that in a minute. There's just something about that at the very last that refers to the use of ipilimumab in brain metastases of melanoma, which is that they're not believed to get into the blood, into the brain, even when there's disruption, as we heard about so elegantly from Dr. Grill this morning. But the T cells do, and that's readily been shown. They're flexible, they can crawl through. In fact, I think one of those papers was called Capture, Crawl, something, which is showing that the T cells can get into the brain. So here's a picture from Axel Hoos, and Jed Walchuk was on that paper as well, and has really taken this show on the road very nicely. And again, I'm not going to go through the details. It's a little bit hard. You got to sit down with this one, but I would be happy to share these slides with anybody who wants, or for those who like to look at the primary reference, you can jot down the JNCI in 2010 was where this was published. The ipilimumab toxicities, of course, are all immune-related, just as the benefits are. And they tend to be they have tended to be associated with responses, but unfortunately not close enough that you can really see patients and decide anything about continuing or not continuing based on whether they have those immune toxicities. You have to base continuing or not continuing based on how severe the toxicities are and not their likelihood of having a response. This is a picture from a paper that was just published this year on pooled studies by Dirk Schadendorf and a number of others, which were phase 2 and 3 trials in melanoma using ipilimumab. And this trial, the reason the red dot was actually not on the slide from the paper, but it's been used by a number of people who report these data, including myself. There were over 1,800 patients, and the median survival was nearly a year. This was the first time we saw this kind of a median survival in melanoma. I think more importantly is that there's a plateau. There seems to be a plateau there with a point of change in the downward curve that we're so familiar with in melanoma that changes at about 3 years, after which time there's almost a plateau. And this is something we're looking for, except we want it to be higher and higher with the PD-1, PD-L1 axis blockers, and then even better, hopefully, with new combinations, including the combinations of the CTLA-4 and the PD-1 blockade, but other drugs that are coming along that I'll show you at the end. So this is an exciting curve, but it's only the beginning. So this is the study that I ran together. It was originally a cytokine working group study, which is a group, used to be a small group, now it's a fairly large group of investigators in the U.S. who've been working together since about 30 years ago, from 1985, who wrote a trial. It was an investigator-sponsored letter of intent to BMS, and then BMS was interested enough in this trial that they took it over. And that's kind of along the lines of what we were hoping when we talked in the workshop report outs earlier. Sometimes you need the company, sometimes you don't. The analytic group that we wrote the statistics based on was a group of 51 patients with a two-stage accrual design that had a futility for the first 21 patients, which thankfully we passed. And then there was an exploratory group was actually suggested by the company in which we allowed patients. So the first group had patients who were not steroid dependent and who were asymptomatic. In the second group, patients had to be neurologically asymptomatic as well, but they could be on steroid up to the equivalent of 10 milligrams of dexamethasone for control of edema, as long as it was a stable dose. The endpoints included the objective response rate in the CNS and of course safety, but the primary objective was the CNS objective response rate, and we also followed the extracranial response rate and global response rates and a variety of things with regard to toxicity. This trial did not have substantial laboratory correlates at that time. The result in cohort A, the analytic cohort, which were the asymptomatic patients with no steroid, was that the CNS benefit rate, remember that's the PR plus a defined stable disease rate at least 12 weeks and confirmed by a follow-up scan, was 24%, a little higher using the immune-related response criteria. That would correspond to just one patient. And for extracranial benefit rate, it was a little higher, but if you put the two together, you got 18% or 26 by IRRC because of the fact that there was a slight discordance there just because of the measurements. There was maybe one or maybe two more patients who benefited in the CNS and didn't benefit sufficiently extracranially and vice versa. But the numbers, if you just look at the numbers, and for those of you who are familiar with ipilimumab or who know somebody who is, that's just about what you see with extracranial disease in patients who don't have brain metastases. So that was a pretty exciting result for us. The toxicities were exactly as we would have expected, and we did not see any unusual CNS toxicities such as excessive seizures or bleeding or other things that are not normally associated with melanoma. And so, as you can imagine, the most common reason to go off study was progressive tumor. This is the survival curve from the initiation of therapy for the two cohorts that we treated in this. And, you know, the bottom one really is, you can't say much about that because it was only 20 patients and, you know, one responder and so forth. So it's really cohort A without steroid that also appears to show a plateau, although this was fairly early. We updated this study and also made a comment. There was an expanded access trial before ipilimumab was approved for use that had 165 patients with brain metastases, and they didn't really do rigorous measurements of their responses, so all we had was survival, but those survivals were essentially the same. And so again, there appears to be somewhat of a plateau that's clustering now over time points that are longer than what I just showed you. Just a few pictures, and I didn't put in red arrows, but you guys are all pretty neurologically and neuroradiographically savvy, so you can tell what's happening here, and I want to just go through that. So now turning back to the power of PD-1 axis blockade, there has been in systemic disease in patients who either never had brain metastases or who had brain metastases that had been treated and were controlled for some specified minimum amount of time, about a 30% response rate. So that is actual RECIST objective responses, and then there's a little bit difficult to state extra, you know, benefit of maybe 10 or 20% in those patients. And those initial data were after ipilimumab or some other therapy, sometimes even after BRAF inhibition for patients who had a BRAF V600 mutation. It did appear that there was an earlier response, a deeper response, and possibly a more durable response in the PD-1 blockade patients, although that remains still a bit too early to state. There's clearly a much lower rate of toxicity for PD-1 and PD-L1 blockade, with most of the toxicities being the same immune-related, but there are some odd sort of one-off things that you see occasionally, including pneumonitis, including nephritis, neuritis, and a variety of odd things such as endocrinopathies without full-on hypophysitis. They're treated as they come, the mainstay, of course, being steroid, and then secondarily infliximab and other secondary immunosuppressive agents. It has been said that there's a low rate of what I'd call escape relapses in the CNS, meaning patients who were controlled extracranially and who then develop evidence of CNS metastasis, but of course that needs validation. These are some early graphs from Suzanne Topalian, who, after the first phase 1 study, published the sort of longer follow-up of nivolumab, and the left side is progression-free and the right side is overall survival. I was a little perturbed by these curves because they didn't really look like they had plateaus, but as I say, time will tell. This moving on to what's now approved, which is a combination of nivolumab and ipilimumab. This waterfall plot, which was really one of the first to be seen for immune therapy. We don't tend to use waterfall plots for immune-based therapy, but this one was very dramatic, and this was all patients treated at what became the recommended phase 2 or general use doses of nivolumab and ipilimumab. So there were quite a few very good partial responses, even some complete responses, and a very long apparent duration of those responses, again, pending longer-term follow-up data. These curves are a little harder to see, but this was from the New England Journal, showing that this was the study 06, BMS's study, which is the basis for the approval, and it was nivolumab versus ipilimumab versus both together, and they showed that there wasn't enough follow-up time to demonstrate any differences in survival so far. Time will tell, but the progression-free survivals were distinctly different between ipilimumab and either of the other arms of treatment. The differences aren't much between nivolumab and the combination, but then if you broke the data down, there seemed to be a greater dependence of nivolumab benefit on the expression of PD-L1 by tumor and less dependence when you gave both drugs. And so there are some individuals who say that that's what they're going to use to decide whether to give patients both drugs versus one. I think it's probably still somewhat controversial because the assays for PD-L1 are quite different, and they're not reliable or extremely validated. So I think the jury is really still out on that. Safety, it's been noted that the toxicities of this combination are quite a bit higher than ipilimumab and even more toxic than nivolumab alone, but it's the same spectrum of toxicities and the same general treatments. And so there are some very specific guidelines that are now, I can say they're in the package insert, but they've also been disseminated in protocols and in meetings, so there's no shortage of guidelines. And now actually they're being incorporated into the what we use in the U.S., sometimes the National Comprehensive Cancer Network, so there will be plenty of places to look those up. The trial that's ongoing now that I started and Hussein Taubi has been running, but again, it's a trial that was written as an investigator-initiated but then became a BMS trial, is a trial of the combination of nivolumab and ipi at those same doses for patients with melanoma metastatic to the brain. And while it originally required extracranial disease as well, the company decided they were also interested in allowing it for patients who only have brain metastases. So that'll be a separate subset. It'll be a much smaller subset. But it's important to note that this trial is specifically for patients who have not been previously treated with either of these agents. So it's that niche of patients who present with brain metastases when you first stage them for their metastatic disease and before you start therapy. They may have had SRS, but that would be a pretty unusual presentation that a patient hasn't had any systemic therapy, but they've had SRS for one or more brain metastases. It may happen if they have very small volume extracranial disease, they get treated to one large metastasis in the brain, and then they have small asymptomatic ones that that are amenable to systemic therapy. And this one also does not allow any therapeutic steroid, only replacement if they had, for example, ipilimumab, which is only allowed in the adjuvant setting, for example, from the large EORTC trial. I got this slide just a few hours ago from Anna Maria Di Giacomo, who is in Siena, and she and her colleagues in Italy have been working on the second of two trials from the Network Italiano. The first one was, I have in the next slide, which I'll go to. Actually, sorry, I think I summarized it. Maybe I skipped over it. No, I guess I forgot to put it in. Anyway, so they had, there it is, 10 of 20 patients on photomustine and IPI in the NIBIT-1 trial were apparently benefiting from therapy, 50%, which sounds quite amazing. But this was, again, an unplanned subset, so you really don't exactly know who those patients were. They had a median survival in that same range of about 11 to 12 months. So what they originally designed was a phase 3 study of photomustine plus or minus ipilimumab. Photomustine is not incorporated, is not approved in the US, but it is approved in several European countries. But then in discussion with the company, they were allowed to and encouraged to open a third arm of the study, which is exactly the same as the study that we're doing, which is nivolumab and ipilimumab. I'm not sure if their eligibilities are exactly the same, but they're probably similar, and they'll randomize patients 1 to 1 to 1. They've got around 38 patients so far on that study, and I think the total accrual is in the 120s is the goal. So some thoughts about radiotherapy, and this is the one where I'll show you some pictures. I'm just going to read you the slides because I think they're very important, and then we'll finish up pretty quickly after that. So, you know, as a former bone marrow transplanter, you know, it's been drummed into my brain that if you give total body radiation, you can only give a small dose because, you know, you cannot upscale it from animals. Animals can actually tolerate a lot more per kilo than people. So total body radiation is used as immune suppression in transplant so that you can accept the donor marrow. And if anything, what you see is graft versus host disease. So the graft takes over, and the patients are quite immunosuppressed from that. And of course, the drugs that are used. Local radiotherapy can be either immunosuppressive, immune stimulatory, or maybe neutral, I don't know, depending on all sorts of parameters, including the schedule, the fraction sizes, the size of the port, I'm sure, and a whole bunch of other factors that a variety of people in all over the world are really looking at. I just threw in a question of whether VEGF blocking, which has been used for radionecrosis, and it's been used in conjunction with chemo for a whole variety of tumors, might be an immune modulator that you could use on in combination with other immunotherapies with stereotactic radiosurgery, because we know that it has beneficial effects against the immunosuppressive phenomena on dendritic cells that come from secretion of VEGF by certain tumors in particular, such as renal cancer. So this is one of those pictures. I don't want to go through the picture per se. You have the reference here from Quinn Lee at Stanford. But I do want to show you a couple more pictures which were published in this very nice review by Sandra DeMaria and Silvia Formenti's group. And to point out that, so these are the slides I really want to go through with you. So the initial steps in a tumor that's exposed to radiotherapy include what they would call, and I think Laurent Zitvogel would also call, an immunogenic form of tumor death, in which calreticulin translocates to the dying tumor cell surface. These innate to adaptive autophagy mediators such as HMGB1 are also released, and ATP, and then there's uptake of tumor antigen by dendritic cells and presentation of that antigen to the T cells in the draining lymph nodes and elsewhere, and maybe in the tumor itself. There's then activation of DNA sensing pathways by tumor-derived DNA, which Tom Gajewski and others have written quite a bit about. induced by interferon beta as well as alpha, which further activates certain subsets of dendritic cells. And then you get this immunogenic go signal, which is in green on that slide, that's then countered by immunosuppressive or stop signals that include TGF-beta induction of inducible Tregs in the periphery, CSF1 that stimulates myeloid-derived suppressor cells, and the overall balance among the green and the red is what probably determines what's going to happen next. In this next picture, this is the only other one. The subsequent events include T cell recruitment and infiltration into tumor, macrophages, which are reprogrammed to secrete nitric oxide, which can be vascular normalizing, although it can also be vascular permeabilizing. It enhanced secretion of the chemokines that listed there that can recruit CD8 cells, which is what you want in the tumor, as we heard earlier. VCAM1, which allows their extravasation further into tumor, and then the upregulation directly on tumor by radiation of MHC class 1, which is required for peptide presentation to the antigen-presenting cells, to the T cells, ICAM, FAS, NKG2 ligands, all of which are activating ligands for cytotoxic lymphocyte activity against tumor cells. And then this form of adaptive resistance, the expression of the de novo expression of PD-L1 on tumor, which is a kind that you may want because that's the kind that lends itself to blockade by an antibody against PD-1 or PD-L1. So some moles, as you heard during most of the day, are much more dangerous than others because they have a lot of molecules that can cause them to eventually metastasize to the brain, which is what we're here for. And I'm not going to pretend that these slides about the origin of brain metastases should be today's conclusion slides, because what we heard today was far more erudite than anything you're going to see on here, which came from literature as old as 2 or 3 years ago. So I'm not even going to go over this because I think this becomes somewhat primitive in relation to what we heard today and in the interest of time. These are some of the molecules in the literature that have been associated in the other metastases or in the primaries with the eventual development of metastatic lesions in the brain. And Anja Berghoff taught me from one of her papers that there is a high rate of PD-1 expression, and here's some subsets of subsets that most of the tumors have CD3 infiltrates. Most of those infiltrates were CD8s. That's really great. Most of those were antigen experienced, and more than half of the TILs were PD-1 positive, as you'd expect in antigen experienced cells. Just under half, we'd like to see that even less, were FOXP3 positive, and just under half of the TILs were CD20 positive or B cells. Half of the tumors express PD-L1. That next sentence has to do with the assays, and when it is expressed, of course, we know that it's associated with PD-1 expression in the tumor cells, the CD3 and FOXP3 expression on the TILs. And so these are just numbers, not necessarily that tell us anything that tells us what to do, but just gives you some thoughts as you design some of your therapeutic investigations, whether you're a lab investigator or a clinical one like me. I'm not going to go through this clinical data because, again, these were older from more disparate reports. And I think I'm going to also skip through the microRNA data that are the main focus of much of what the NYU group has been doing in terms of trying to understand metastatic melanoma, and in particular metastatic melanoma to the brain. So this is the last bit, just 2 last slides, kind of a listing of some of the other agents that, or some of the other targets, I should say, of development of antibodies and other approaches to inhibit that which causes brain metastases and what causes these tumors to proliferate and survive and to resist apoptosis. They include other checkpoint molecules such as LAG3, TIM3, VISTA, TIGIT, other molecules that are part of this hypoxic axis, such as VEGF and hypoxia-inducible factors, STAT3, IL-6, and then, of course, the killer immunoglobulin-like receptors on NK cells that recognize MHC class 1 and actually deactivate the NK cells in contrast to the NKG2D that I mentioned earlier. Other things that are secreted in the tumor microenvironment that are suppressive include enzymes such as indolamine dioxygenase, arginase, that both deplete the important amino acids as well as causing toxic metabolites. IL-10 is suppressive, IL-6 is suppressive, STAT3 is responsible for a number of downstream expression of suppressive genes, and TGF-beta. Inhibitors of some of those immune suppressive cells in the tumor microenvironment include immune suppressors of Treg cells and of tumor-associated macrophages or myeloid-derived suppressors. Now, it's important to know that some of those tumor-associated macrophages can be polarized towards type 1, secreting things that we want to help the T cells kill tumors, or they can be type 2, which do the opposite. And then there are co-stimulatory agonistic antibodies that are very exciting, such as antibodies to OX40, CD40, glucocorticoid-induced TNF-like receptor, 4-1BB, and ICOS. And then cytokines, as I mentioned earlier, IL-2 and some derivatives of IL-2 and IL-15. Those are gamma-C or common gamma chain receptor cytokines that are important for growth and proliferation and activity of T cells as well as NK cells. So I'll stop there, and I'll tell you that that's the status report, and c'est l'état du champ. Merci de votre attention. And if you have any, that's Stanford, and that's Lake Union next to the Seattle Cancer Care Alliance, where I used to work. And it's up to our chef whether we do questions or not. Maybe you have a glass of wine and I can answer questions later.